Welcome to my presentation on fruit and vegetable consumption among American Indians and Alaska Natives, hereafter referred to as Native people. We'll start by exploring the 5 W's and H, the who, what, where, when, why, and how affecting this population. Per the U.S. Department of Health and Human Services Office of Minority Health, there are approximately 5.7 million Native people in the U.S., which is 1.7% of the total U.S. population. There are 574 federally recognized tribes and 100 state-recognized tribes. Compared to non-Hispanic whites, Native people have a lower median household income, and fewer aged 25 and older have attained at least a bachelor's degree. 22% of Native people reside on reservations or trust lands, with 60% of Native people residing in urban areas, which is the lowest percentage of any racial group. Diabetes is a serious global health concern affecting an estimated 415 million people worldwide, with the number expected to rise to 642 million by 2040. Diabetes claims the lives of 5 million people per year, and healthcare for people with diabetes costs approximately twice as much as those without the condition. The health effects of diabetes can be devastating. People with diabetes face the risk of blindness, kidney failure, macrovascular disease, as well as heart disease and stroke. While diabetes presents in several populations in the U.S., the Native population has the highest prevalence of the disease within all ethnic and racial groups, with a prevalence of more than 2 times that of the general population for those aged 20 and older. Diabetes is the 4th leading cause of death for this group. Diabetes has been shown to occur as young as ages 15 to 18, according to the Indian Health Service. More 2010 found that type 2 diabetes increased 68% among Native people from 1990 to 2004. Risk factors for developing diabetes include an unhealthy diet comprised of processed foods and foods high in fat and sugar, effects of colonization on subsistence farming, and the lack of access to traditional food practices, which has created food insecurity. Government food commodity programs replaced traditional foods with foods that were foreign to the native diet and higher in fat, sugar, and calories. Another risk factor is lack of physical activity. Factors that protect against developing diabetes include eating a healthier diet, including greater consumption of fruits and vegetables, and increased physical activity. Diabetes poses a serious health risk to the Native population, and it's critical to intervene now. As mentioned previously, the Native people have the highest incidence of diabetes within all ethnic and racial groups in the United States, and a prevalence of more than 2 times that of the general population for those aged 20 and older. Intervention is especially critical because the disease is increasing at an alarming rate among Native people. Social determinants of health exist at multiple levels for Native people, including the individual, family, community, and tribal levels. There are several social determinants of health which affect Native people, including environment, culture, socioeconomic conditions, living conditions, education, and food pathways. Now we'll discuss the impact of social determinants of health on fruit and vegetable consumption among Native people. Only 21% of adult Native people eat the USDA recommended number of fruit servings, and only 34% eat the recommended number of vegetable servings. Native people are less likely to eat the recommended number of fruits and vegetables when compared to white, black, and Hispanic populations. Poor nutrition, including not consuming enough fruits and vegetables, is a risk factor for developing diabetes. Jernigan et al. 2018 studied the social determinants of health affecting the diet among Native people in Oklahoma. Study participant data showed 65% shopped at convenience store or gas stations once or more per week. 56% traveled more than 20 miles round trip to shop for groceries, which is the USDA's definition of a food desert. 49% reported eating 1 or more meals per week from a convenience store or gas station, and 38% said in the last 12 months it was sometimes true that they purchased food that didn't last and they didn't have money to buy more. Participants also indicated that fruits and vegetables were cost prohibitive in their town. Let's now view the consumption of fruits and vegetables by Native people through an ecological lens. There are several levels of the ecological model. At an individual or interpersonal level, inhibiting factors can include lack of knowledge of how to shop for or prepare fruits and vegetables, and the inequities of cost and lack of availability of fruits and vegetables in the local community. At the interpersonal level, family can be both a positive and negative influence on the consumption of fruits and vegetables. The self-efficacy of minority adolescents was bolstered by hands-on learning in purchasing foods at a grocery store and by parents modeling eating behaviors and involving youth in cooking at home. One of the barriers to fruits and vegetable consumption by minority youth included family members who do not like fruits and vegetables. Communities can collaborate to increase the consumption of fruits and vegetables. This was seen when children, teachers, and elders came together to support a classroom indoor gardening effort by Aboriginal First Nations children in Canada, and when Navajo Nation members planned, participated in, and benefited from the increased consumption of fruits and vegetables from their community garden. At the organizational level and policy levels, Native people are still feeling the effects of colonization with a loss of tribal lands and a place to grow traditional foods, which were replaced by unhealthier government-funded commodity foods. Theories of behavior can help us to understand the factors influencing the consumption of fruits and vegetables by Native people, including risk and protective factors. In a study by Phelan and Smith 2006, the theory of planned behavior showed that the behavior of healthy eating was influenced by different constructs according to gender in Native adolescents. While both genders' engagement in the behavior was influenced by subjective norms, Native boys were influenced by perceived behavioral control constructs, whereas Native girls' eating behaviors were determined by self-efficacy and barriers, which included the unavailability of healthy food. Urbanovich and Bevan 2020 studied the health belief model within the context of adult natives and other minorities attempting to adopt a plant-based diet. Perceived barriers to adopting this diet included shopping, preparation, eating out, and eating habits. Perceived benefits include health, well-being, and convenience. While the perceived threat of disease did not influence the intent to adopt a healthier plant-based diet, self-efficacy, which was expressed in confidence in shopping for and preparing plant-based foods, cues to action from friends and nutritional blogs, and subjective norms via the influence of social relationships did. Studies by Hildebrand and Betts 2009 and Hildebrand and Shriver 2010 demonstrated that how a behavior presents can be determined by which stage of the trans-theoretical model an individual is currently occupying. For example, regarding providing fruits and vegetables to their children, parents and primary caregivers in earlier stages of change provided either smaller or fewer servings of fruits and vegetables to their children, used fewer processes of change, and had lower self-efficacy for engaging in the behavior. Both studies also found that factors of self-efficacy, time, and cost had a direct effect on the behavior as both barriers to enacting behavior and influencers of decisional balance. Studies by Trude et al. And Franco et al. 2013 emphasized that self-efficacy is critical to the consumption of fruits and vegetables in minority youth and is associated with higher levels of fruits and vegetable intake. Self-efficacy of minority adolescents was bolstered by hands-on learning in purchasing foods at the grocery store and by parents modeling eating behaviors, an example of vicarious experience, and involving youth in cooking at home, an example of enactment. For Trude et al. 2016, an additional protective factor in the form of social support came from schools, with students showing increased vegetable intake during the school year. This was in part facilitated by free and low-cost meal programs. Barriers and risk factors affecting fruit and vegetable consumption included inaccessibility related to the distance to the grocery store, cost, and interpersonal factors such as fruits and vegetables being inconvenient to eat and family members not liking fruits and vegetables. Interventions developed using the theories of behavior we just reviewed can be used to influence the consumption of fruits and vegetables among Native people. Peterson et al. 2013 implemented an intervention using the theory of planned behavior to improve diet on the Navajo Nation by increasing the availability and consumption of healthy foods. Community workshops were held to educate the population and promote healthy food choices, preparation, and consumption in conjunction with food stores. Components of the intervention reinforced each other, resulting in healthier food choices and increased knowledge and skills. Wright et al. 2018 created an intervention using the health belief model to increase fruit and vegetable consumption among minority food pantry participants. The fundamental barrier for participants, which was access to fresh fruits and vegetables, was resolved by the distribution of fresh produce at the pantry. This served to remove the barrier and increased perceived access to produce, as well as increased food security levels. Self-efficacy was strengthened by education regarding produce preparation. Increases were seen in the health value associated with produce and an increase in the confidence of using produce. As a result of the intervention, participants increased their fruit and vegetable consumption by almost 2 servings per day. Denoya et al. 2008 focused on creating interventions using stage-matched processes of change to meet minority adolescents at the stage of change they were currently in to influence their consumption of fruits and vegetables. Program participants increased their intake of fruits and vegetables by 38% more than those in the control group and showed increases in perceived pros of eating 5 or more servings of fruits and vegetables. They also progressed to later stages of change and maintained the target behavior of eating 5 or more daily servings of fruits and vegetables. Determinants et al. 2017 designed a community garden intervention using constructs of the social cognitive theory to improve health of the members of the Navajo Nation. More than half of adult members of the Navajo Nation consume less than 2 servings of fruits and vegetables combined. Ornelius et al. 2017 found that barriers to consumption of fruits and vegetables include lack of access to fresh fruits and vegetables, high cost, and barriers to growing fruits and vegetables. The following constructs of the social cognitive theory were utilized when designing the intervention. Collective self-efficacy. Community members participated in and collaborated on the development of the community garden and the related educational curriculum. Knowledge was built via workshops, and the community garden plot served as a classroom. Behavioral capacity was addressed by practicing planting, weeding, and gardeners were provided with a food preparation demonstration. Self-monitoring and goal formation. Workshop participants set goals for creating a home garden and received feedback from instructors. Social norms. Gardeners shared ideas with each other, and the garden was shown off to other members of the community. Culture was honored. Native songs and blessings were a part of the garden. Results of the intervention per Ornelius et al. 2018. A majority of the participants reported high self-efficacy for eating fruits and vegetables daily and for preparing them. Gardening frequency was higher for those with higher gardening social norms. There was a positive association between fruit and vegetable consumption and gardening frequency. The gardening more than 4 times per month resulted in people eating 1 more serving of fruits and vegetables per day than those gardening 4 or fewer times per month. For my intervention, I've chosen the social cognitive theory to create a community garden on reservation lands to increase the consumption of fruit and vegetables by Native people, increase their access to fruits and vegetables, decrease food insecurity, and increase food sovereignty and autonomy. I propose using the following construct. Collective self-efficacy. Involve the community, including children, in designing the garden and choosing what is grown, including traditional foods. Knowledge and inactive attainment. The community garden can be used as a classroom with instruction by local and regional master gardeners and farmers on how and when to plant and how to prepare the harvested fruits and vegetables. This can increase self-efficacy. Vicarious experience. New gardeners can learn by watching more experienced gardeners. Behavioral capacity can be strengthened by practicing planting and receiving feedback from more experienced gardeners. This can also increase self-efficacy. Address goal formation by having participants create a garden plan by mapping out what they want to plant, when and where, and receive feedback from master gardeners. This too can increase self-efficacy. There are several ethical considerations with this intervention. To ensure it's culturally appropriate, provide information on and encourage growing traditional foods. Honor tradition and invite elders and other community members to bless the garden. Barriers and burdens also need to be addressed, including the cost to garden. Transportation to and from the garden is a cost. I suggest carpooling to mitigate this factor. Seed grants can be written to purchase seeds and gardening tools. To address watering costs, I propose a combination of traditional plots and vertical gardens which save water and space. Gardening takes time. To address this, I suggest creating gardening cohorts composed of friends and/or family members that share the garden responsibilities. Adoption by the community is another factor. It's not realistic to expect the community to quickly adopt major behavioral changes without continuing to ensure the success of the initiative. This support can be provided through a multi-year grant and continuing education. Accessibility. Provide garden plots that are adjusted in height for the elderly and wheelchair-bound. The potential health benefits of this intervention include the increased consumption of fruits and vegetables, which acts as a protective factor against diabetes. Gardening is also exercise, which is a protective factor against diabetes. Thank you for taking the time to watch my presentation.